So as always, so this is about learning, this is about asking questions, this is about figuring out stuff so we can kind of get it going more efficiently out on the floor. We're going to just, there we go, cardiac arrest update. So let's just kind of go over some of the newer nuances of taking care of patients who just kind of arrive in full arrest like we just had in room 1, all right? So a lot of this is going to be stuff you guys know already. So much of this also then is going to be more on how can we get a more efficient process going, and what are the new sort of updates that go along with ACLS. So some ACLS-based stuff, and then some other kind of practical kind of stuff. All right. So again, ask questions whenever. But let's just start off. Let's just let's go for it. We got a 78-year-old male in room 1, unresponsive, is getting CPR and is getting bagged. Here's the patient. What are we going to do? Come up around. Who's the man? What do we want to do? All right.
Hook up the oxygen.
Okay, we're hooking up some oxygen on him. Okay. Okay. So we're gonna get some pads on him. What have we got? We've got the. So we're gonna go CPR. Okay. So who's going to do CPR?
Okay, well, got it.
Okay, all right, so we've got CPR, okay, so someone's got a bag, okay, alrighty,
Make sure he has a line.
alrighty, okay, we're gonna get a line in.
Okay, just pretend you're bagging.
Bagging, okay, yeah, I guess we could put a bag on, alright, so somebody, there we go,
So
someone's
we're
got a bag.
trying for a line on this side and that side.
Yeah, how's our CPR going?
We're almost at 2 minutes.
Okay, you're doing CPR, okay, what else do we need to kind of get going on here?
We got the line.
We've got a line, we've got all pads, okay, alright, so.
Second drawer.
Some pads coming, okay, alright.
So we got a
we can
line
put them
now.
on, okay, we've got a line and we've got some pads going on and you're bagging. So let's say, I'm going to sneak behind you, let's say, alright, let's say this is kind of what we're seeing on the monitor, right?
We got some B-fib going on.
B-fib,
Horse B-fib.
okay, alright, alright. B-fib,
So
B-fib it is, what are we doing?
We want to defibrillator.
Defibrillator, okay,
Put
okay,
it on, Jill.
okay.
Charge that baby up. Our pads are in place. There you go.
Kim, room 16,
Got it.
please. Kim.
Okay.
Still doing how many stops?
Yeah, okay, yeah, we're still doing CPR,
So
okay.
now, lead two.
Okay.
Okay, so we're on there and
No,
we want to
we want a shot because it's
shock.
B-fib.
Okay, perfect, yeah, we need a shock. Okay, so how are we going to do
So
that?
do I actually, well, it's select your energy, right? And it has. Okay.
Full steam ahead. right?
Okay.
Okay, there we go. So max defib. Okay, so we're going to shock. All right, so everybody clear and we're shocking. Okay, bang. All right, so the shots and now what happens? We're going to continue CPR. All right, so epi, so we've got some epi. You want some epinephrine? Okay, we're getting a one-touch going. Okay.
Okay. So Epi's in.
What else? Anything else we can do?
Getting ready to intubate.
Check up all.
Could be. So we're going to start intubating.
Before we
Okay.
Oh, yeah.
Checking a pulse with that. We got somebody set up for like intubating. Who's going to set up the intubation? Do we need any other medications? Amiodarone. Okay. Got some amiodarone. Capnography. Okay. Let's say. Okay. So capnography is. We've got capnography up and in. Okay.
I'm taking notes.
You're taking notes.
I'll tell you when it's
Okay.
been 3 to 5 minutes.
Okay.
for
All
the
right. Okay. All right. Someone's getting notes. So we've got. So is the epi in?
Epi's been in for
Okay.
2 minutes.
Epi's been in for 2 minutes, and we've got some amiodarone in. Okay, so we're continuing CPR. All right.
Are we ready for a pulse check?
Okay, let's do a pulse check. Okay, all right. Let's say it's still the same.
Still the same.
Yeah.
We're going to shock it
Shock
down.
again. Okay. All righty.
Fire up
Shock.
that.
Fire it up.
Fire
Okay.
up that machine.
All right, so we're still on defib.
Yeah.
We're energy 200 charge. I'm clear, you're clear. We're
Everybody
clear.
clear? Shock.
Shot.
Okay.
Shot.
Bang.
CPR.
Shock. Okay. All
CPR.
right. So we're gonna carry on our CPR. Let's say what else? Anything else we can do? Any other thoughts?
Well, we can consider all the H's and T's, right? Is he still in defib?
Gretchen, call the desk.
Could be. The computer's thinking about what he's in at the moment. All right.
And
So
we're doing
perfect.
CPR,
All right.
and we
Yep.
need another epi
Yep.
then. Just spend between 3 and 5 minutes.
Okay.
So
Perfect.
another
So
epi.
continue with the epi.
An epi is given?
CPR is going very well.
Yes.
Very
Okay.
well.
I'm getting tired, are you getting tired?
And we're ready for intubation whenever the doc is.
Yeah, we could be.
But we're bagging effectively, so we're good there.
Dr. Crillo, line 2,
Okay, good. So
surgery.
carry on doing anything else.
Dr.
Anybody else
Dr.
want to
Crillo, line 3.
I'm actually getting the ultrasound set right
I
up
just
there. Should we
realized-
try that?
Yeah, I was
Yeah.
saying.
we're listening. Have a kaleidoscope, just to clear and cool.
We have our airway.
Good. All right. Well, we're getting there. So the
Okay.
computer's thinking about it. And looks
Chris,
like-
Tower 5, line 3.
So we've got 2 lines and we've got normal saline pouring in. They're related
Do we
twice.
need to give that?
The what?
Bicarb. Ask the family what their treatment is on, what can cause them.
Okay.
Oh, baby.
There we go. We got.
Is there a pulse? Do we
All
have
right.
a
Oh,
pulse?
somebody's a
Right.
pulse. Okay, I like it. Okay, do we have a pulse with this? So there's no pulse with this?
No pulse.
Okay.
Continue CPR.
Okay, all right, continue CPR. Okay, all righty.
Aaron, to the desk for report, Aaron.
We can do some
Or
atropine, yeah, okay,
how fast or?
Okay.
40s.
It's
We're
kind
giving
of,
2 Eppies. I did not
kind
take
of
time
slow.
for Epi.
1, 2, 3, 4, 5, 6, 7, 8, 9, divided by 300. It's almost like 33 at the moment. Slow. All right, epinephrine, carrying on.
Mhm.
Okay, so we could do some more epinephrine. We could carry on. Seems like we're kind of going downhill. We're
Pressure.
nothing. There's no pressure with this.
Yeah.
No
And
pulse,
we're
no
considering
pressure.
all our H's and T's,
H's
right?
and
We've
T's,
already-
okay. All right, what are some of the H's and
What are the
T's?
H's? Hypokalemic?
Okay, could be hypo or hyperkalemic or
Right.
hypokalemic. All right, okay. All right.
What else?
He is 78 though, do we know anything that?
Don't know anything about it. Yeah, yeah.
I think that's not, my mouth is still numb.
So, I mean,
I
the
wouldn't
patient
even
hasn't been
notice if it's
in a
any
trauma, right? So it wouldn't
No,
be
no
a-
trauma. Let's say
wouldn't
no
be
trauma
any-
in this one. So
so
not so
there's
much
no
of the
T's
T's.
for
It's
there,
mostly
so the
mostly
H's are
H's.
okay.
Okay. All right. So there are a bunch of them.
We are.
Hypoxia, hypoglycemia, hypokalemia. Alrighty, let's take 5 then, and let's talk about this now. And I just kind of wanted to put the case kind of right off the bat over there. And you know,
Sorry.
it's like between everybody, we kind of got all the elements. You know, like a little bit of kind of thinking but let's see. Let's critique kind of what we were doing. We'll go through the lecture and see maybe could there have been a better way to do this? Could we have been a little bit more organized? Do we have a system where we just sort of going backwards and forwards? Was it smooth?
No.
No, not really, right? Okay. Do we really do a lot of arrests that really go smoothly?
No.
They're tough, right there. It's like, you know, it's like everybody's kind of in, everybody wants to do everything. We kind of need to do it all at once. What comes first, what comes second? It's a tough one. I mean, arrest and it's tough to think, right? And inevitably the equipment fails halfway through and you can't really think straight and there's a little bit of flustering kind of involved, right? So let's just, all right, so, you know, kind of ways we can look at things, and what I like to do is, I think probably the most, so with arrest situations, all right, time is everything. Okay, the sooner we can get stuff done, the better. This is kind of one of the critical ones where time is really meaningful. All right, if they get here or if they kind of arrest while we're here, if we can get early intervention and we can get a result early, we've got a chance of these patients perhaps being able to leave the hospital neurologically intact. All right, so if we've got any way we can get that heart started ASAP, it's going to be good. So time's important. So if we know we've got a full arrest coming in, usually we do. Occasionally it happens right in front of us in the hospital or in the ER here, that's fine. So I think for me, like the first couple of minutes before the arrest arrives is like an important time. And let's just think of like trauma at the same time. So we can actually get ourselves organized beforehand. You know, I think one of the areas where we don't do as well as we could, and I think we need to practice this, is assigning responsibilities before the patient comes in. To me, that's like an imperative part. If like the patient rolls in and everybody knows exactly what they're going to do, because what, we had like 10 things simultaneously that kind of needed to be done. Bagging, end-tidal CO2, CPR,
IV.
get an IV started, check the pulses, put them on the monitor, who does what, you know, and then, you know, the doc will say, all right, what's the blood pressure, and 4 people will try and go and get the blood pressure set up, but, you know, and we get this big tide of everybody sort of going from one task to the other. So let's, you know, so being able to get tasks identified in those first couple of minutes, okay? You know, everybody should know, you know, what it is, what task they're going to do. When that patient walks in, if you know what you're going to do, you don't even need to really be talking about it anymore. It actually keeps everything a lot more quiet, and when things are quiet, it tends to be a lot smoother as well. Part of our kind of running around is everybody shouting and talking and trying to get all the information and this, that, and the other. So let's, we're going to get back to, actually, I think I've got some handouts of this. Let's just kind of regroup and sort of reorganize the way. You can take one and hand it out. We should get these kind of posted up in rooms, and that's going to be my goal. Get these up in every single room. Okay, so whether this is a trauma or full arrest kind of coming in, let's get ourselves assigned beforehand who's kind of do what. So head of the patient, so this is kind of the left-hand side coming up here. This is where the med card is and the defibrillation, the monitor, everything like that. So we've got Tech 1 on this side, all right? You know, and these are the main assignments to Tech 1 on this side, all right? Now, it could be that they're going backwards and forwards doing CPR, so we'll put CPR at the top of the list. Usually, if the rescue squad is going to come in on the right-hand side, Tech 1 on this side is going to, or Tech 2, I should say, is going to start the CPR kind of right away. Just most convenient, that's your first task. If someone is coming in having CPR, this is the top of the list, and you kind of get to going CPR right away. And you're going to alternate with the 2 techs doing CPR depending on who's getting tired and what other tasks need to be accomplished, okay? The tech on this side, all right, is primary job, get the patient on the monitor, get the defibrillation set up. If there is a pulse or there's something kind of going on, we're going to kind of get vitals going. So that's this tech's task, kind of right over here. Nothing else should kind of interfere with that. This is the order of stuff. This is kind of what we're going to want to see kind of right away. The first question the doc's probably going to want to know is, what's the rhythm? All right? So without having to even ask kind of what it is, if we know somebody is here on this side, getting the things set up to put them on the monitor. All right? The nurse on this side, here with the meds, is just ensuring we've got some sort of IV access somewhere. Okay? Usually kind of coming in with IV access, or maybe they're going to need it in a quick go. And we've got medications over here, and this nurse is going to be going with the medications. Task oriented, that's what we do. Don't need to worry about anything else. The tech on this side obviously starts off with CPR. If it's not necessarily a CPR case coming in and it's a critical trauma case or something else going in, they're also primarily responsible for the airway stuff. So this tech on this side is like, I am just going to really focus on, if I'm not doing CPR, I'm getting airway stuff ready if it looks like it's going down there. So the airway would be whatever oxygen they happen to be on or needing, getting suction going. All right, so those are your main focus, is either CPR or airway issues on that side. The nurse on this side, if we happen to have a second nurse in the room, yes, if we can get an additional IV access going, great. It'll be, these come later down the road. If we need any other little procedural stuff going, we're usually not going to need NG tubes or Foley tube right away unless you've got a Pete Ferreira code. Then we'll need a Foley a little bit more quicker, right? No. So these sort of come down lower down the thing, but primarily if we've got a second nurse who can be doing documentation and just making sure we've got a second IV established. If we see a first IV, we know it's a critical patient. Chances are they're going to need a second IV. Probably no need to ask. We can just go in, get second IV access on that side. So focusing a little step back again, the first 2 minutes, while we can get things set up. So the tech on this side, this is the stuff they should be responsible for, getting into the room and making sure set up. So the airway, since your airway issues, we want the airway set up, we want the roll done. If we're going to go to intubate, you may not know that yet, but we're just at least going to have the roll unrolled over there. We'll have the glide scope in the room, all right, and ready to go if we know it's going to be an immediate intubation. And we're going to bring the airway cart in, all right? I think we do a bad job as doctors of not having that airway cart available. And then when it all hits the fan, now we've got to go running around. Who knows where the airway cart is? Right now, where is it?
Oh, right now.
Yeah. District 7?
Like right outside of District 7.
District 7.
Oh, that's what I was going to, when you first go back to District 7.
Okay,
Right
all right.
above the respiratory cover.
Okay, all right, so good. So half of us sort of know where the airway cart is. That's good. All right? Chances are when you really need it, there's going to be some people who won't know where the airway cart is. But I think it's something we should have in the room, because it's the last thing you want to do is suddenly when you lose the airway, you can't intubate and the patient's like paralyzed, is to go running around looking for the cart. And the docs, so this is where it's really good. So a good tech is going to kind of have the airway cart in the room. Doesn't need to be opened up, but it's there and it's ready to kind of open up if we need it right away.
I already started.
Okay.
It's right here.
I started it because I didn't know you had it.
Okay. The other things which we're using much more and more, I'd like to kind of see, and anytime we've got an arrest or anytime we've got a trauma, ultrasound should be set up. Okay. We don't have the machine in here, but the probe we use, we can go over that afterwards. It's really helpful to have the ultrasound machine switched on. It doesn't need to be plugged in. The battery's going to last the duration kind of while we're there. Have the probe set up with the kind of gel ready on it. About half the time, the gel's not available. So, and that can also, suddenly you can't kind of get any good pictures. So have the ultrasound set up and have it open, have it switched on, probe's there, gel on the probe, then you can just grab it. You want to take a quick look. One of the whole things with ultrasound is we're going to use it more and more and we'll go through, but it's got to be kind of a quick look. And the quicker we can just get that quick look, the quicker we can get back to CPR if that's what we need. We want to minimize interruptions. If it happens to be a trauma, we're going to have the chest tube set up on this side. If the patient needs a right-hand side chest tube, this tech is responsible. The tech on that side, Tech 2, is responsible for having chest tube stuff set up. If you know it's going to be a trauma, just have one of these little tables, just with the chest tube stuff closed on there. We can put it back in the thing if we don't use it, but kind of have it there ready to go, because if we need it, we're going to need it quickly. All right? This side, the things which we're going to set up, it's more the vitals and everything, and the pads usually are kind of there, but that's what we're going to need right away. If you know there's an arrest coming in, may as well get the pads out, ready plugged in, kind of set up, ready to go. We can just stick them on and quickly have things ready to go. Again, if it's trauma, we're going to have a chest tube up over this side, at least just waiting to go if we need it. All right? And then finally, an IO setup. All right? We should have one available every arrest, every trauma patient, because if we really can't get IV access, we don't want to go running around now looking for the IO kit. Let's have it here, have it ready to go. It's just one less thing we need to kind of faff around. If it's there, bang, we can put it in. So does that sort of make sense? Any other people got any other thoughts about that? Suggestions? Concerns? Anything else we've missed?
What if your eyes in a code, I was the only tech in the room?
Yeah.
The nurses kind of like stood back.
Okay.
Like they weren't like as present for like helping.
Yeah.
So, I mean, granted the doctor let the Lucas stay on until the battery died.
Yep. Yep.
However, what would you do in that situation?
Okay, so I think that's kind of a useful situation. So great, this is perfect scenario. We've got 2 techs, we've got 2 nurses, and that works half the time. And the other half the time, we don't have that. I think that's a perfect scenario where if we just discuss a little bit beforehand who's going to do what when the patient kind of comes in, I think it would be a lot clearer. So everybody's sort of looking at you suddenly to perform 2 roles, and nobody's really identified, well, who's going to be sort of tech 2? And the tech is doing the BLS stuff, which is like the important stuff right away. I mean, this stuff is probably more important than the IV kind of going in right away. So I think that's a great role where it's like, okay, you know, let's define who's going to do what. Depending on what it is, but let's say it's an arrest, you know, I think kind of on this side, you know, the tech doing, there's going to have to be one person assigned to doing CPR. If we have a Lucas going, great, but if not, it's one person kind of doing CPR. I think the other person's just going to be, whether it's a tech or a nurse, if we're kind of limited, getting the thing on the monitor, getting kind of vitals set up, and just seeing if we've got anything going there would be the 2 most important issues, and then we kind of move down to the airway. And again, it's just, yep, we don't have, not often or not always are we working in the perfect scenario, so great to chat beforehand. Okay, what are you going to do? What are you going to do?
And is that the responsibility of the nurse in the room?
So ideally, right, it should be like, listen, if the doctor's in the room, it would be great if he kind of came in and assigned, okay, we're going to do this first, we're going to do that second, we're going to do that, and we're going to go walking in. But everybody's got a slightly different way of practicing, right? I think this is helpful if we standardize, okay, and that's nurses and techs, kind of the way at least we organize ourselves in the rooms. Pretty much going to be the same stuff going to go, which regardless of, you know, which doc is doing it, they may do things in a slightly different order, but we're going to need CPR, we're going to need things on a monitor, going to need an airway done at some stage, probably going to use the ultrasound at some stage. All right? So I would say it's much better to take the responsibility ourselves, yourselves, to be able to organize things up this way. You know, much better. Half the time the doc may be organized, half the time the doc may not be organized. But if we've got our own system beforehand, sometimes the doc's in the room, right before we've got the 2 minutes, we know the full arrest is arriving and the doc's in the room, and you'll be like, if he doesn't lead, then go ahead and say, well, okay, guys, let's start getting ourselves organized. If he does, great. But again, they haven't had this lecture. All right, so this is something we want to just start fostering, so everybody at least knows. After a while, this will become automatic, right? We just know exactly who's going to do what, what's going to do what, and it all kind of falls into place.
I think the district nurse, if she's comfortable, should lead
Yeah.
who's doing what
Yep, yep.
ahead of time.
Absolutely. So I think as you walk in, and again, it could be just like you look around the room, who's here, all right, who's really going to be the one taking the lead if the doctor isn't there? Somebody's going to step up, okay, assign task quickly, da, 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 da.
I think it's a good idea to have these in the rooms because, I mean,
Exactly.
we,
Yep.
even 2 years into it, I still kind of fumble. I think EBCs, I'm not
Yep.
thinking organize the room,
Yep.
it's just,
Yep.
you do.
I think that's in the works.
So since it hasn't happened, I'm going to get these laminated, and we're going to stick one up in every room.
Perfect.
Right?
Yeah,
Eventually
that's
there'll be a
in the
nice pretty
works.
paper, and we'll do that, but you know, the good plans
We talked
today is better
about
than the
it
perfect
in
plan
the,
tomorrow. Yep.
in the, skills line.
Yeah, perfect. So we'll get this going, and as everybody's sort of following the same thing, it just becomes a little, and you save an awful lot of time when everybody knows going in. If we all suddenly go to tasks, because each of these tasks independently take a few seconds, really.
Right.
And boom, 4 things happen at the same time, you know, suddenly it's all done in 15 seconds, as opposed to, you know, watching one person do it, and then what's going to happen next, and, you know, and so we're kind of working in great fashion there. So that's, you know, a very important part then of this is really getting ourselves organized. It's not really complicated stuff. Everybody knew the stuff that needed to be done. We know we need to do CPR. We know we need to bag the patient. We know we needed to get the patient on the monitor. We pretty much knew the meds we needed. We knew we had to defibrillate the patient. So we all inherently, for the most part, kind of know this, but it's getting this sort of organized and getting into nice systemic flow. And the more we start practicing in a systemic, cohesive way, we can start flowing that out to others. All right? So, what I want to talk about then, let's just go over, so what are the new recommendations for ACLS? Of course, it just changed last year, and they brought out their new recommendations, and every year they have to change the recommendations, and we'll go over the reason why. We kind of think just as soon as we've learnt it, right, they change all the freaking recommendations, and now it's this med, and then it's that med, and they change this year we do that, and then the next year is like, oh, absolutely, we don't do that, and we're like, what the hell? And it's like, how can this be like so important one year and then completely we don't do it the next year kind of thing? So I just want to give a little bit of background. And so basically, you know, ALS stuff and BLS stuff should be kind of based on literature and should be evidence-based, like all the practice we do. And so the way we kind of look at evidence is, first off, we say, well, what is the level of evidence that we're basing our decisions on? Is it really high-quality evidence? Were these really good studies that were done and definitively prove like a cause and effect? Or were this just like sort of so-so quality evidence from maybe some anecdotal stuff? You know, or was it we get down to the bottom, low quality evidence where there really isn't any evidence at all, but people just think, yeah, that probably makes the most sense, okay? A little bit dry, but we'll get to it in a moment. And then they make some recommendations, and they say, okay, based on the evidence that we have, is this really a great idea? All right, strong recommendation. Is it just like, yeah, we probably should do that, or is it like, you know, this is neither really here nor there, or is it going to cause harm? Okay, so just out of interest then, so when we kind of go through, let's see these slides kind of come up. So let's start off with the strength of recommendation. So this is kind of how much they believe, the people who, when the ACLS team kind of get together, all the doctors, the cardiologists and the trauma guys, and they kind of get together and they say, okay, which of the recommendations we make in our ACLS and BLS protocols are really strong recommendations? Because we don't know, we just told we do this, we do this, we do this, we follow the algorithm. Which are really strong? Well, only 25% of those recommendations, for this is life-saving stuff, are really like strong recommendations. Moderately, maybe another 25%. Nearly half these recommendations or these guidelines that we follow are really just weak strength of recommendation. It's just people thinking, yeah, I kind of guess we should do it, all right? We don't know that. We just see the algorithm at the end and say, oh my God, we've got to absolutely do this. But, you know, keep in the back of the mind, it's like, you know, half of the stuff which we're doing is really just really kind of weak recommendations. Like, yeah, you know, it's not going to hurt if we do it. All right? And then when we get to the level of evidence, it's even more. So we break it down into the pie chart, all right? This is, you know, strong level of recommendation, moderate level. This is just weak level of recommendation, and there's a chunk there which is like, we actually know it's going to cause harm if we do that. All right? And now we go into the more
Housekeeping to room
frightening
16,
stuff. So
please.
we
Housekeeping
go,
to
so this
room
is
16.
evidence-based stuff. So how much of this ACLS resuscitation, like the cornerstone of what we do in the ER, right? How much of this is based on really high-quality evidence? 1%. It's a little bit eye-opening. Moderate quality evidence. 30%. Moderate is not even great evidence. And then this is low evidence, or just people sitting in a room thinking, yeah, you know, we probably should do that. It kind of sounds like the right thing to do. Now, granted, these are, you know, not silly people making these recommendations, but just so we kind of get a background where these things are. So 3/4 of the things that we're doing in ACLS are just sort of based on this opinion, which is a big reason kind of why it changes every 2 years, because these opinions change all the time, because it's not really based on very strong evidence. So it's not like, you know, people are kind of going willy-nilly. The evidence that we have is relatively weak. You know, they're going to take thousands of people, and maybe they did all this stuff, and, you know, when you do the procedure, 2 people get better. When you don't do the procedure, 1 person gets better. Well, you look at the statistic and say, oh my God, there's a 50% improvement if we do the procedure, because 2 people got better instead of 1. But it's only 1 person who really kind of changed the outcome. And next year, you repeat that study, and that 1 person who happened to get better last year didn't get better this time. And so suddenly now, there is no this 50% improvement. It's actually a 25% reduction. And so suddenly now they say, no, 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 we can't do that. This is the reason why these recommendations change all the time. Okay, so just to kind of keep that in the framework of the background of this stuff, all right? It's scientific as much as possible, but it's not really high science, and it's tough because you can't just, you know, voluntarily like we're going to kill you guys and we're going to see what happens when we do these interventions, right? Or we're not going to do CPR on you because we just want to see whether that's better or not. Nobody's going to really agree to those kind of things. So it's very hard to do a real good study, right? So we do the best we can. So let's go over the new recommendations, all right? So for BLS, when we're doing our CPR, all right? They kind of made things a little bit easier. We really want to go fast and hard is sort of what we're looking at, and they're just trying to make it simple. We're just looking for a rate really above 100 to 120, nobody's really counting, but we're going pretty fast, all right? We don't distinguish anymore whether it's an adult or whether it's pediatric, all right? If it's an adult, we're going with the 2 hands and we're kind of going right in with our shoulders, right? We're going down. We'd ideally want to compress a couple to 3 inches. I don't know how on earth you measure that, so it's kind of one of these recommendations which is kind of meaningless, but we need to kind of go in pretty deep, and it's not a bouncing thing like this, all right? It's a squashing thing. We kind of want to get, it's not a good dummy to do CPR, but we want to squash that bone down and not just like bounce off it like that. We're actually looking to squash that bone down. We're trying to massage the heart, all right? But we want to massage it quickly. So fast rate, hard CPR. The key thing about CPR, if you remember one thing, the couple of things we want to do, put in red, is to minimize interruptions. If you start CPR, we just really got to continue CPR as much as possible. We've got a tendency to start CPR, then we stop, do something, maybe we intubate the patient, okay, start CPR again, okay, stop, let me see what the heart rate's doing, okay, stop, I'm going to put some medicine in. That kind of CPR we know doesn't work very well. All right? So the trick is we want to try and minimize the interruptions as much as possible. So we want CPR to continue, and try and get our interventions done around the CPR. Okay? So we try and put the pads on while CPR is still going. Some people will just put the pads on the front so we can carry on doing CPR. But generally we can put the front pad on with CPR going. We might be able to slide it, but whatever we can do to minimize the interruptions. Because if we continue doing good CPR, we're keeping the brain perfused, it works a little bit better. All right? Just in terms of the breathing, the breathing's become a secondary issue. All right, we've done too much breathing for all the patients, but we generally don't really count 2 breaths for every 30 compressions. Although that's kind of the way, you know, it really should be. Generally, we bag far too much and give them more oxygen than necessary. You know, again, this is based on a very low-level recommendation, but breathing's less important. We're trying to get the heart started. All right. If it gets to the point where oxygen becomes an issue, we're probably well down the road. Very unlikely chance of getting this patient back. We'll get to that in a moment. Whether we do mechanical compression, that's with the Lucas device doing things, or whether we do our own good CPR, there's no difference. It's not like the Lucas is better. If somebody does poor CPR, the Lucas is better. But generally, we're trying here, we do good CPR, fast and hard, squashing. It's the same as doing the Lucas. The beautiful thing about the Lucas is it frees up a body, which is far more important than anything. But in terms of quality of CPR, they both do very well. Okay, So this is it. So this is the BLS recommendations. It hasn't really much changed. They're trying to get it as simplified as possible. It's just the same rate, adults, kids, 100, fast, deep, minimize interruptions. All right?
Could we suggest to the doctor to wait to intubate?
We'll get to that in a moment. So great thing. When do you intubate a patient, right?
It's not really the tech's fault
Yep,
or the nurse's
exactly.
fault.
No, the doc's going to be driving that. So perfect. We'll get to that. It's a great question. All right. So let's go through. So if we've got an arrest, we've got an asystole arrest, flatline. Okay. So, you know, epinephrine. When you look at a lot of studies, in the end, epinephrine doesn't make one iota of difference for the patient leaving the hospital alive. Whether they got epinephrine or didn't get epinephrine. But the problem is the data is not that great studies. There is some evidence now showing that, look, if we're going to give epinephrine, let's give it as early as possible. It's the same as defibrillation. Either defibrillate early and definitively or don't do it at all. It's going to have its best effect early on. Epinephrine is shown to have a better effect early on. So this is more for the outpatient kind of stuff. I mean, most of the arrests, it's when the EMTs kind of get there. But if it happens to kind of go down in front of us, or we happen to be the first on the scene, if we can get epinephrine early, it actually has a bit of an effect. If we give it late, it's meaningless. All right? Epinephrine really, and there's a study coming up I'll show you. All right? They've taken vasopressin out. It was just as good. Doesn't make any difference. They just want to keep things simpler. It's like epinephrine. And epinephrine is just, think of it as just the fluid to get the heart started again. That's really all it does. It's the starting fluid for the heart. All right? If the heart stops, we give epinephrine. All right? Give it early rather than giving it late. All right? So it has a little bit of effect. But generally, there's a study which we'll get to in a moment. Okay. Post-arrest. All right, so if we happen to get them back and we get pulses back, and there may or may not be any neurologic response, but if we get them back, we are doing the temperature management, the hypothermia protocol, or the target temperature management, whatever you want. This is stuff which is based on very, very slim evidence, which changes every year as to what we're going to do. A couple of years ago, we were really looking to get patients really, really cool. Every year it seems to be like the level that we've got to get them to starts to be increasing. So really the goal now is actually just, really we just want to get them down to 36 degrees Fahrenheit, all right? Centigrade, sorry. And you know, normal temperature is 37, 38. So we're really just trying to prevent the fever. It's not so much that we've got to drop that temperature critically, all right? But we do want to get this. We're not going to start it outside the hospital, but we do start it in the hospital. We're going to start it down in the ER. Most people are probably familiar. But again, if we get somebody back, we get a return of pulses, we're going to start the hypothermia protocol in the ER. We just call up to CCU. They pretty much have the stuff. And basically, we're going to put cooling pads in the armpits and in the groin. We're going to start some cooling fluids on the patient. Cooling blanket will come down. It's probably all overkill because that's really all going to drop the temperature of the patient quite quickly. And we don't have this dramatic goal where we've got to get them down to 20 degrees Celsius. No, we've got them dropping down like 1 degree Fahrenheit. And then they've got a probe which they can put in. We're using a rectal probe here, right? Or are we using the Foley probe? Foley probe. Okay, so we put the Foley in, and we just can keep the core temperature monitored that way. All right, it's not critical whether we do all of them at the same time, but basically we just want to get the process started of gradually, slowly, just preventing the patient from running a fever. We think that a lot of the damage or the post-arrest damage is done from the inflammatory response that happens after the arrest, and that produces a fever, and we're trying to avoid that fever. That's what we think at the moment. Everybody's going to sit around the table next year and come to a different consensus opinion. But that's where it is at the moment.
Dr. Gurley, if they're already below 36 before doing any intervention, do we need to still do cooling blanket, ice pack?
No, so once we get there, once we reach our goal, all right, good to have the probe in so we know when they start warming up, but you know, I wouldn't put anything on. We've reached our goal, so we can take it off. We can have them on the blanket, although not turned on, so if they start increasing temperature again, we can react quickly. But if they've reached the goal, we're done. Yep, don't institute anything. Yep. So again, obviously, yeah, winter time, once the patient's all undressed and they've done their CPR for 20 minutes outside, chances are the patient's going to be kind of at that temperature already. PCI, we kind of ruled more gearing towards this. So again, this is, we kind of know now that if it looks like the patient had an actual cardiac arrest or a STEMI, which caused them to go into arrest, or after we get the resuscitations back, they have what looks like a STEMI on an EKG or a VFib, we're going to try and get them up to the cath lab, all right? Because chances are it was a thrombus in the heart which caused the arrest, which caused them to go into that. So we try and see we get them up to PCI. So there's more and more push to get to these patients. If we get anything back, and there's any evidence this is an MI as the primary cause, they should go up to potential PCI. All right, still on asystole. So listen, here's the bottom line. Asystole is still bad. It's basically you're dead, all right? And nothing's really changed much with that. If your heart stops and there's no activity, it's stopped and there's no activity. It's very difficult to get a meaningful response back from asystole. Essentially, if we've done 20 minutes of good quality CPR, the medications which we have available to us, which is really just epinephrine in this case, all right, and there is no response after 20 minutes, survival chances are way less than 1%. So it's basically considered this as medically futile. So 20 minutes of good ACLS with asystole, and nothing is back from that point. It's a futile endeavor to continue doing anything at that point. We really don't see anything. Sometimes we can get the heart started again, but it's not like this patient is walking out of the ICU a few days later. They stay in the ICU forever until we decide to terminate it days down the road. So really this is sort of what we're looking at. That's the evidence. 20 minutes, give it good, hard, aggressively, as much as possible for those first 20 minutes and see if we can make a change. But after that, 20 minutes of no blood supply to the brain, we're done. Okay. All right, so that's with asystole. Now, things may change now a little bit with PEA. Okay, so this is where things kind of change. In the past, we looked at PEA more like asystole, right? It's like the heart's not beating. All right, well, actually, it turns out maybe there's more evidence that actually this may be more survivable. There may be some stuff that still seems to be like there's some electrical activity going on in the heart. Is there anything we can kind of salvage going on? So we definitely give this more of a run for the money, okay? If we've done it 20 minutes, is too soon to call a PEA. All right, we really need to kind of take it up. We've no reason not to take it up for a good hour of aggressive intervention, all right? If we've got what looks like a salvageable person with PEA. It's not a dialysis patient, okay? This is presumably somewhat relatively healthy, okay? But after 60 minutes, even that becomes medically futile, okay? However, so what we're going to look at is say, well, there are some things associated with PEA which actually give us a better chance of actually getting a return of spontaneous circulation. So if we've got heart rates, if their PEA rate is above about a 40 to 60 kind of rate, they've got a much more success of actually converting over back into a normal heart rate versus a PEA with a rate of 5. Just this occasional which is not doing anything. But if they've got a good organized rate, which is kind of going along, 80 beats per minute, it's like, there's still something going on in that heart there. Let's see if we can salvage it back, okay? So high heart rates are a positive predictive value for this. And the other thing is, and we'll talk a little bit more about it, is kind of monitoring the end-tidal CO2. So this is very helpful. We'll get that onto the next slide, is kind of monitoring. So the end-tidal CO2 tells us if the body is really still alive. So if the body's producing carbon dioxide, then obviously stuff inside the body is working because the cells are breaking down oxygen and everything and producing CO2, which is kind of coming out. So something is still alive somewhere. So if we've got an end-tidal CO2 that seems to be increasing as we resuscitate this patient, then something somewhere is happening inside this patient. Whether we can see an objective pulse yet or not, that remains to be seen. But something's happening if the end-tidal CO2 is going up. Versus we're doing aggressive resuscitation and the end-tidal CO2 is just going down and down and down and down. It means the body is dead. It's not producing any carbon dioxide. It's shut down. All right? So we're going to look at PEA now, and PEA kind of comes more in when we look at the factors, when we look at the EKG associated with PEA, is it narrow complex? All right? And if it's narrow complex, it means that all the electrical activity in the heart is actually doing really good. It's got a nice, organized, proper QRS complex that's kind of beating along. It seems to be like, man, that heart is healthy, all right? It's got a normal-looking beat associated with it. It's just not pumping properly with that beat. So we start thinking, okay, there seems to be a mechanical problem that's preventing that heart from beating properly. So we look straight away to say, is there anything that's impinging on the heart from beating properly? It's trying to. It's got a good electrical system going there. The starter motor's going, but the engine's not turning over at the moment, okay? So So this is where we start thinking, do these people have a tension pneumothorax? All right, so there's big high pressure in the chest, which is squeezing on the heart and preventing the heart from beating. This is a quick and easy fix, with life-saving fix for a patient. Bang, okay? You know, could they have you know, tamponade or something or around the heart itself, and that's where the ultrasound is very useful. It can put a quick probe on the heart, and if you see a ton of fluid surrounding the heart and the pericardium, it's like there's a ton of fluid which is squeezing the heart, and we need to put a needle in and get that fluid out. And if there's issues like that going on, you can get a miraculous, suddenly, return of life from these patients who beforehand, before we had an ultrasound or didn't really know, we would just assume, look, it's PA, we don't have a pulse, bye-bye. No, there could be something salvageable. Now, these are not like high occurrence things, but if they're there, we have definitively saved a life. All right. All right? And so with this one, again, we've got a good electrical activity. We try these things, we should give fluids. We want to try and get that heart pumping something out. It needs some fluid to pump to kind of get going again. So these are sort of the things we're looking at versus the wide complex PAs, and you just see this big kind of wide, oftentimes will be a horrible looking kind of complex associated with that. And we think, okay, wait a minute. This is affecting the electrical conduction system of the heart. So it's something systemic is going on. They're going to need some medication which reorganizes the electricity in their heart. So do they have a metabolic problem? Are they profoundly acidotic? Okay. Do they have hyperkalemia? This is like a classic one, all right? So they come with this big, horrible, wide, complex kind of thing looking, and that's the potassium getting too high. We can give some calcium right away. So if it's a PA with a big, wide, complex, let's shoot some calcium. You know, it's reasonable. In the past, we say, well, there doesn't seem to be an indication. No, there is a good indication to do it. We could give some bicarb in this instance, okay? Because could this be a toxicologic kind of thing? Is there some overdose, perhaps, or some other kind of toxicologic issue that's caused them to have this, affected the electrical contractility of the heart? All right, so we're kind of looking it up that way. Putting the ultrasound on the heart is very useful early in these cases because it can help us sort of divide out these things as well as getting what the rhythm is looking like. So PEA is getting a little bit more scientific on how we're dealing with it. All right? All right, so again, PA, the end-tidal CO2 is really becoming beneficial. We should kind of get that plugged in right away on these patients, all right? And it gives us a good, I mean, if we're doing all our interventions and the CO2 is actually rising, indicating that that patient is producing more and more carbon dioxide, it indicates the patient is something is still alive and perfusing well. Versus a decreasing CO2 level with all our interventions, this patient is dead and dying, and if there's no CO2, then that's dead. So it's a very good adjunct tool for us to help us with our arrest patients. Ventricular fibrillation, all right, so that hasn't changed from last year or anything. We know that, you know, in VFib, they're still very, very salvageable. Chances are this patient had a heart attack, right, and has now gone into ventricular fibrillation. We want to get him out of that defibrillation as early as possible, and everything should focus on defibrillation, all right? We don't want to waste any kind of time and don't let anything delay the defibrillation because this is their best chance. If we can zap them out of this zap them out of the fibrillation, all right, and get them back into an organized kind of rhythm again. So getting back to some of the things, it's like, so for patients in ventricular fibrillation, I don't want to tool around intubating the patient. That just delays the definitive care. I don't want to mess around any other intervention at this stage. I don't want to mess around